Welcome. I'm Dr. Sunil Jindal, a reproductive surgical medical specialist. I've been trained to do microsurgery for the last 25 years, and I'm doing Micro-TESE for over a decade. There's so many things which I have been able to learn, which I understand, which today in the Fertility Catalyst Series of ISAR, I'm going to bring to you every doctor of the country for you to understand and learn so that you could be of great use to your patients, because I'm going to speak today about Micro-TESE in Asuspermia. It is just not a surgery, it's a mission to help people who do not have any sperms and they want to be their own biological father. So in this session, I'll teach you everything what we do behind the microscope. Precision, patience, passion together would create miracles for you and for us. And because we as doctors want to skill ourselves and upskill ourselves, this is for you. And it is also for those couples who do not have children to see this video to understand what exactly a top center in the world is going to do. So let's go right in to this particular video. You would love this. So today I'm going to talk to you about something very interesting. Azoospermia. Matlab azoospermia. Why does azoospermia happen? What is the reason? How will you diagnose what kind of azoospermia is there? What are the different techniques by which you can get the sperm? आपको sperm कैसे मिल सकता है so that you actually will be able to use it by ICSI to give a baby to the couple? And I'm going to take you about Micro-TESE through the journey. I've had this amazing journey, मतलब मेरी बड़ी कमाल की जर्नी रही है Micro-TESE की. और जर्नी इसलिए हुई कि मौलाना आज़ाद मेडिकल कॉलेज में मैं आपसे पुरानी बात कर रहा हूँ, करीब ये बात हो कि 94-95 की. हमारे एक प्रोफेसर थे, प्रोफेसर RCM Kaza. Brilliant man. So my professor used to do microsurgery on the testes, and he used to do VVA, VAS together, VEA, and at times he used to get on to the journey where he used to be working after opening up the testes to find sperms. And after finding a sperm in 3 hours, he would normally tell us, Jindal, I have found a sperm. And I always used to say, what will you do with that sperm? And this happened, but when in 2004 we started doing ICSI, I realized the dots have connected, and this is where the sperm needs to be used. And that's how it was used. So it accidentally started in my life with this, because of which countless number of children have been born to parents, in fact, fathers who did not have a sperm. And for a father who doesn't have a sperm to have his own baby is priceless. And do we realize that we all, as doctors, work day in and day out, giving our time individually to every human being, trying to relieve their pain. And the pain of azoospermia is very deep. It becomes a psychological issue as well. And for to give an azoospermic man his own child is just so satisfying. So I'm take you through this whole journey, and this whole journey is very interesting. So I will go on to the first slide, which is understanding azoospermia classification and pathophysiology. Now, please understand that azoospermia per se is divided into two types of azoospermia. Number one is obstructive azoospermia, where an obstruction is there, which is about 40% of the patients. And there is non obstructive azoospermia, where the spermatogenesis is impaired due to testicular function. Now, this is 60% of the cases. Now, it's very important for us to define it, because if we don't define it, we won't be able to go in further. Now, what are the causes of obstructive azoospermia and non obstructive azoospermia? So, obstructive azoospermia per se has a few characteristics. There is normal spermatogenesis, there is a mechanical obstruction in the reproductive tract, accounts for 40%, and has good prognosis. तो ये एक ऐसी जगह होती है जहां पर कोई ना कोई ऑब्स्ट्रक्शन है, पर क्योंकि एक स्पर्म की बनावट, स्पर्म की मैन्युफैक्चरिंग इज गुड, so we are able to get sperms easily. Now, the other is non obstructive azoospermia. Now, non obstructive azoospermia means that the testes has an impaired spermatogenesis. Testes का sperm बनाने का तरीका is poor. And this is because of testicular dysfunction. 60% of the cases are like this. And this is what needs to be actually treated by Micro-TESE. Now, let me be very, very clear with you. A very large number of patients fall in the purview of a central area. You cannot diagnose them for sure whether they are obstructive azoospermia or non obstructive azoospermia. A lot of people are in the midline. So, this judgment needs to be done on table at the time when you are operating. I'll also give you another important thing for you to understand that people with cryptozoospermia या जिनके sperms बहुत कम हैं ना के बराबर हैं गिनती के sperms हैं and these sperms are not good in quality. In these patients, when doing ICSI, the best sperm is a testicular sperm. A lot of literature is there on this. There is a major study of Steve's, and this major study shows clearly that a testicular sperm is better in very, very low sperm count. So, this becomes another indication to operate on these people. Now, let me talk about the pathophysiology of non obstructive azoospermia. So, obstructive, we have understood that obstructive could be in the vas, it could be in the epididymis, it could be in the prostatic area, could be in the seminal vesicle area. But non obstructive azoospermia is something very interesting which we need to understand. So, it can be either primary testicular failure, which includes genetic disorders like Klinefelter syndrome, Y chromosome microdeletion, cryptozoospermia, varicocele, idiopathic cases. Or it can be secondary, which is hormonal imbalances, gonadotrophic exposures or systemic disease, or a mixed pattern, which nowadays I'm finding very, very common, where there are different areas of the testes which have a different function. तो देखिए अगर आप इसको गौर से देखें समझें तो आप ये रियलाइज करेंगे कि क्लाइनफेल्टर सिंड्रोम is not as uncommon as you think. In fact, Klinefelter syndrome is a very common thing happening. So these patients of non-obstructive azoospermia need to be diagnosed as the cause. देखिए एक चीज बहुत simple है. I always say, whenever there is a patient of azoospermia, you need to diagnose the cause of azoospermia. And once you have found the cause of azoospermia, you will know what exactly you need to do. So there are three types of azoospermia. Number one is pre-testicular. Pre-testicular means कि आपकी टेस्टिस से पहले ब्रेन से हॉर्मोन्स कम बन रहे हैं. So hypogonadotrophic hypogonadism. In hypogonadotrophic hypogonadism, the best way to treat this patient is with HCG and HMG. This normally we would give to patients who do not have sperms and low FSH and low LH. So the first baby which we gave of hypogonadotrophic hypogonadism is a very interesting story. So this lady came to me, very rich lady, and I had known her for a long time. So she came to me and she said that I know somebody who has this report, showed me zero sperm, then showed me a low FSH, low LH, and said this is the other report. And this was diagnosed when he was 15 or 16. अब शादी हो गई है, शादी होने के बाद में 2 साल हो गए हैं. So I just looked at her and said, what do you want? She said, I want to buy the most expensive sperm in the world. I looked at her and said, कि सबसे एक्सपेंसिव तो मुझे पता नहीं, पर सबसे वैल्यूएबल स्पर्म आप ही के बेटे का अगर मिल जाए तो क्या होगा? Because I knew, she told me later that it's her son. After some time she told me. So we gave him HCG, and after giving me HCG, we had testosterone come back. We started HMG, and after about 4 months, when he gave another semen sample, I got a call from my lab. My embryologist, I love him, he's such a darling. And he said, Sir, sperm dikh gaye. I said, wow. We did an ICSI, first cycle did not get pregnant. Second cycle got pregnant. Finally had two beautiful baby girls. I think they're 15 years now. I think 15 or 16, something around that. And but there was a big problem, and the biggest problem was she said, "You've given me two girls. Is there any way I could have got something else?" So I told her, "This is something which can never be done, will never be done, and is not possible." So if you go into this story, you'll realize that from that time till now, हाइपोगोनेट्रोफिक हाइपोगोनेटिज्म के अनगिनत बच्चे हम पैदा कर चुके हैं। और पता है सबसे अच्छी बात क्या होती है? At times you can actually get very good sperms because hormone ही तो नहीं मिल रहा है. That testes is waiting to be started. Next comes obstructive azoospermia, which I told you about. In this obstruction, you can get sperms, and these sperms from the epididymis can be as good as an ejaculated sperm. And third, of course, in non obstructive azoospermia. So, now how and what do you do to examine this patient? Now, any patient who comes to you with azoospermia, you have to see the secondary sexual characteristics. आपको देखना है उनके characteristics कैसे हैं, are hair there or not, what is the body, what is the way the chest is. You need to see testicular volume. See, normal testicular volume is about 20 cc, and the largest diameter in the testes should be at least 4 centimeters. If it is less than that, then it's a smaller testes. So smaller testes will probably be non-obstructive azoospermia. Then you have to palpate the vas and the epididymis. This needs to be done to see if there is any kind of the absence of vas, which happens in cystic fibrosis. You've got to examine the patient and see the varicocele. Now, varicocele assessment becomes very important, and let me be very clear with you. The best way to assess varicocele is manually with your hands. Ultrasound just gives a confirmation. So I would like all of you to get a patient examined. So बहुत बार आपकी क्लिनिक में होता है that you can't examine. So you should have somebody who can examine this patient because an ultrasound cannot replace an examination. And then after that, the next thing is a digital rectal examination. So all these examinations need to be done in any case of azoospermia. 5 चीज एग्जामिन करनी है. सेकेंडरी सेक्सुअल कैरेक्टर्स, टेस्टिकुलर वॉल्यूम, पैल्पेशन करना है, वेरिकोसील देखना है और डिजिटल रेक्टल एग्जामिनेशन करना है. नाउ लेबोरेटरी इन्वेस्टिगेशंस. What investigations do you need to get done? FSH, LH, testosterone, inhibin B people get it done. I don't get it done a lot of times. And prolactin and estradiol if needed, if the weight is more of the patient. You need to get this hormonal investigations. 5 investigations, 5 things to palpate, 5 things for hormonal investigation, and 2 genetic testings. One is karyotyping. Now, in karyotyping, what you actually get done is when will you get a karyotyping done? So, you are going to get a karyotyping done. You will get a karyotyping done when the man is azoospermic or his sperm count is less than 5 million, when the FSH is raised and the testes is small or small. And a Y chromosome microdeletion you will get done when the sperm count is less than 1 million, when there is an elevated FSH level, and when the testicular size is small. So, any of these things which are there, you are going to get a genetic testing done. Now, let me go on to the next slide. What will you see in the semen apart from azoospermia? 3 things. You will see in the semen, number 1, ejaculate volume. Now, the volume should be at least more than 1.5 ml. If it is less, there could be an obstruction. You would like to see the pH. pH normally is 7.2 to 8. And in case there is azoospermia, you would also, an ejaculation as well, you would like to see a post ejaculatory urine analysis. Now, today morning, I got a patient who said he'd come from Bihar. So he had come, examined him, said, I'm an ejaculation I have. I examined him, planned a urine analysis for him. Now, if I find sperms in them, I would know that sperms are being made, and then I could plan what needs to be done. So, it's very important for us to understand these three things in this whole process. Now, how do you differentiate obstructive azoospermia from non obstructive azoospermia? So, testicular volume of non obstructive azoospermia is smaller, FSH level is higher, ejaculation may be reduced, not necessarily. Testicular consistency may be normal, and the success rate is very good to get sperms, about 90%. While in non obstructive azoospermia, you could get a success rate of up to 50%. Now, let us understand another small thing. Most of the patients we get are non obstructive azoospermia. And the second thing is, a lot of people lie in the mid. A lot of patients of FSH normal also turn out to be non obstructive azoospermia. So, this judgment has to be done clinically with hormones, but the final judgment normally is done when you open up the testes. Now, what are the surgical managements, the evolution of the techniques? So, this is very interesting. I'm coming into the techniques now. And if I look into the evolution took place in the era 1990s. So in 1990s, something which was interesting was that you had in the 1990s you had testicular sperm aspiration. So what you did is you put in a needle to get sperms. पर बड़ा interesting बात आप अब ये समझ लो आप ICSI 1992 में. In those days there was no ICSI in India, and at that time sperm retrieval was done by Professor Kaza. And at that time, he used to open up the testes under a microscope to find sperms. So he was ahead of his times. During 1990s, it used to be a TISA or a small testicular biopsies. In 1999, Peter Schlegel did the first Micro-TESE, where he opened up the testes microsurgically. Then the third era, which will be coming in the future, is going to be the era of artificial intelligence and novel visualization techniques. Please understand, today, Micro-TESE is the standard, the gold standard to get sperms. The sperm retrieval is much more. But in the future, there are going to be a few things which will help get even better sperms and more sperms, which I'll show further on in the slides to you. So let's go on to the next slide and let me now go on to the conventional techniques. So the conventional technique, which is very common, is what we know as a PISA. So PISA is when we put in a needle into the epididymis, make a suction, take out the sperm which is there, place it, use it to give an ICSI. This is PISA, percutaneous. And up to 90% success is there in getting sperms. But there is, I'll tell you after showing this video, let me show you this video first. So what we do in a PISA? So in a PISA, we take a butterfly, hold the epididymis between the fingers, the thickest place we can hold. We place the needle inside it. There is a 10 ml syringe which is there at the end, in which suction is given. And giving this suction, we are able to pull and clamp it so that we may get some liquid outside the epididymis. Now, once we have taken this, in this we are going to examine and see if any sperms are present. Now, what is the advantage of a PISA? The advantage of a PISA is कि इसके अंदर हमें 80 to 90% sperms मिल जाते हैं, लेकिन इसके लिए full epididymis चाहिए. And the second advantage we have is it is minimal invasive. You can do it under local anesthesia. But the interesting thing about PISA is that at times the sperm retrieval and the number of retrieval is less. So what we normally do is a microsurgical epididymal sperm aspiration, MISA. In MISA, we open up the epididymis, put a catheter into it, take a lot of material and freeze all these sperms apart from the sperm which we have taken up. So a MESA is better in terms of the number of sperms you can get because you microsurgically are opening up. पर इसके लिए general anesthesia देना पड़ता है. That is one area which is different. Now I will tell you to the next technique, which is a TISA. TISA is when you put in a needle into the testes, minimal invasive, local anesthesia needed. You can do it very, very simply, but the limitation is in non obstructive azoospermia, it's very difficult to get sperms. But in those patients of obstructive azoospermia, in whom you have not got sperms from a PISA, you may get a sperms, some sperms by TISA. TISA is when we put in a needle, just a needle. So TISA per se is not very helpful. About this, we need to be very clear. Now, the third technique is conventional TISA. So what happened? People used to take a testicular biopsy, and the surgical approach was that you could open up the area. You could take a surgical biopsy, use this biopsy, and the tissue requirement which would be there would normally be taken from only one area. It would be used, but the complications normally were very less. पर इसके अंदर करीब सिर्फ 20 to 30% sperm मिलता है, and this is a procedure in which sperms will be only got from one area. What I mean to say is sperms will only be got from one area. So let me show you the video of this. So if you see over here, a small opening is made, and in this small opening, you make an area from which you take a little bit of material, you put this material onto a center well, and you take it. So conventional TSA is normally not done per se in any non-obstructive azoospermia. It can be done in an obstructive azoospermia. Now, the third gold standard which is there is micro testicular sperm extraction. So, now I am going to tell you a lot of things about it. I will tell you how micro-TESE represents the gold standard of surgical sperm retrieval by utilizing a high magnification of 25, 15 to 25x. I normally work on 25x. We've got to identify the optimal seminiferous tubules. जब हम खोलते हैं टेस्टिस को तो उसके अंदर हमें larger tubule, opaque tubule, अच्छे tubule ढूंढ के निकालने हैं. When we do this, we have minimized tissue trauma because we take out very little tissue. When we take out very little tissue, we preserve the testicular architecture because we preserve the blood supply and we optimize the sample quality. See, what happens is we normally take out very small bits of seminiferous tubules from different places. बहुत अलग-अलग जगह से we take out small seminiferous tubules. Now these small seminiferous tubules, because we take them out from different areas, the chances of getting sperms are more because we see with our own eyes the seminiferous tubules, we know the area to take it out from. And since the quantity is less, testosterone goes down less. This is very important. Now, let me also now go on to the next thing. Now, that what is the main takeaway of micro-TSA? So, micro-TSA live birth is higher. A systematic review clearly shows it is the best approach. Now, I'm going to show you stepwise laboratory protocol. Everything I will show you today in this video. Today, we are able to get sperms in 50 to 70% of patients and live births exceeding 40%. But this has been after doing this work for over 20 years. So today in this video, I am going to bring to you everything, everything which I do, which I've learned in the last 20 years. What do I do in the theater? What do we do in the laboratory? What does our embryologist do? Everything from beginning to end, and how do we follow up the patient? So the first thing which I am going to bring to you now is द प्री ऑपरेटिव ऑप्टिमाइजेशन. तो किसी भी पेशेंट को अगर हम लेके आ रहे हैं सर्जरी के लिए, वी नीड टू ऑप्टिमाइज इट, एंड टू ऑप्टिमाइज इट वी हैव टू कंफर्म what is the status. There should be a centrifuge semen sample which tells us. We need to do a genetic and diagnostic workup, karyotyping and Y chromosome microdeletion and endocrine profiling, and at times a scrotal ultrasound, so that we are very, very clear what we are going into. Third is, in case the testosterone is down, we would normally give these patients HCG, or we'll give these patients clomiphene so that the testosterone becomes normal. Why? Simple. For sperms to be manufactured, the intratesticular testosterone should be good. अंदर से टेस्टिस टेस्टोस्टेरोन से ना ही होनी चाहिए, तभी जाके स्पर्म बनेंगे. And this is the reason we need to increase the testosterone. And we also at times consider FNA mapping. Now, FNA mapping is very interesting. I'll show you. It's also known as different procedures, but prior to micro-TC in a lot of patients, I would do an FNA mapping. So let me show you what an FNA mapping looks like. So in a FNA mapping, we normally mark out 16 areas in the testes. How many areas? 16 areas. So what normally we would do is we would open up, we would know 8 are above the equator, 8 below the equator. Now we put in a needle with a 10 or 20 ml syringe, just like we would put in a TISA. We are going to now give pressure, pull the needle out, we get some tissue, but some tubules also come out. Now, these are the tubules which we normally are going to hold, and with a microforceps, go on taking out this tubule till the time we get some tissue. Now, taking out this tissue becomes extremely helpful for us. Why? Because we get a reasonable number chunk of the tissue. Then we pick this up, send it to the embryologist. In case sperms are there, then we know in case they are enough, fine. If they are not enough, then we need to open up the testes in this area. So this is FNA mapping. Now next, I'm going to come on to what is the surgical setup which we normally will have. So the surgical setup we will have is the anesthesia and temperature. So we've got to maintain a temperature of 37 degrees. So it should be a warm room. If you see over here, all our equipment in which we are going to take in the sperm is maintained at 37 degrees. And we need to preserve the spermatogenic cell viability. So I'll just show you what we exactly do. So what we do is we use the same warmer which we use for our test tubes. We have center wells on this which are placed with media in the same temperature which we would use. Now, this is what we would normally do with the opening up. So we open up midline because in this area, the vascular area is the least. So least bleeding takes place. So we open up the testes in the midline. This is what we normally would be doing. Now, the exposure needs to be good. And after opening in the midline, when we open up the testes, I'll come to the next stage. Now, in the next stage, what I normally do is I have a small micro ultrasound. So I use this ultrasound on the testes to see if there are any vessels. Because now the incision which I would give will be the transverse incision. Now, this transverse incision is an incision which would be given by me after an ultrasound. So the chances of bleeding are very less. And what I use is an operating microscope, 15 to 25x. I normally operate on 25 for a micro-TESE and use a micro Doppler with it wherever it is needed. It gives me a better retrieval and it gives me a faster closure. I'm able to do it faster. So I'll just show you this. So if you see over here, this is how a micro Doppler will be used on the testes to judge an area where there are no vessels so that we could open up, because we really, honestly speaking, do not want much bleeding. Very little bleeding is what we really want in this. And let me show you, this is a 25x what we do as a microscope, and this is what we normally are going to use over here. So let me go on to the next slide. Now, how do we do the tissue extraction? So in the tissue extraction, what we normally would do is, our search strategy is very simple. We do a sweep from superficial to deep poles, and excise only dilated opaque tubules. Now, when we do this, there is a 70-fold less tissue excised than if you do a normal sperm retrieval by opening up multiple biopsies. And the tissue quantity is only 10 to 20 milligram per side. And we stop the moment we get motile sperms. So, what happens is that the testosterone, even if it goes down, recovers within 6 months. So, let me show you exactly how we do it. So, what we do over here is we have opened the testes. You can see this is the primary opening up of the testes. And when we're seeing into the microscope, you see this whole area. We start observing from one end. And when we observe from one end and go ahead, this is the way we normally see it. And just see the tissue. It's very little tissue which we actually take out from the testes in these patients. Now, intraoperative decision making, how do we make it? Now, in the intraoperative decision making, the importance is of two things, unilateral or bilateral. So, what, see, I today have done about, um, every month I do about a dozen of cases, more than that, in fact. So, over a period of time, my speed has increased, the way my eyes pick up has increased because this is a job of two things, patience and patients. So, you need patience and you need patience. So now I'm very, very clear that if I have not got something in half an hour in a testes, I move on to the other testes. But earlier, I used to spend more time trying to get a sperm. But ultimately, the moment you get a sperm is the time when you would call it off. Or you come to know, for me, half an hour this testes, half an hour that testes, if I don't find. I probably would get 15 minutes more, but by that time I would have sweep the whole testes. And that's important. And the second important thing apart from the this thing is the intraoperative biologist. So what I normally do is I take a continuous feedback from my embryologist. So we have two tables, so we may have two people working at a time. So what I do is with one main person I have a video call open. I'll just show you what I do. So it's a, you could say, a small trick or a jugaad. So the camera is held normally there, and I would normally be talking after sending, have you found, have you not found, I have found, please send me some more tissue from this area, please send me some from the area which was before. And these are very, very helpful tips to us. So now let me show you how we do a micro-TESE. So let's see this video. So what happens in micro-TESE? In micro-TESE, we open up the testes, and after opening up the testes, we observe under a microscope. So this is the first layer where we are, where we're picking up different areas, taking these areas and taking these tissue pieces after seeing this whole area. This is the first layer. So I told you we open up in layers. So I'm opening up in the first layer. This is what exactly is the procedure of micro-TESE. We would pick it up, send small areas for testing further. So this is what a micro-TESE would look in. Now I'll show you the microscopic view, the way it looks. Next slide. So this is a microscopic recording. If you can see over here, very, very clearly, all these are flat areas, but this is an area on where you can find a dilated tubule. So this is the dilated tubule which you're going to pick up under a microscope. Now this was a patient which I remember distinctly had a late maturation arrest. So this is the picture which looks like in a late maturation arrest. So you'll pick up tubules after scanning everything. So I had opened up the testes, was scanning. These were the tubules which we found over there and took them. You can see over here. This is an area which is going to have dilated tubules. Now under a microscope, you're seeing this, it appears to be large, but it's a very, very small, tiny piece. Very small, tiny piece. Now, these would be processed in the laboratory to find out sperms. अब इनको खोल के हम देखेंगे कि sperms इनमें मौजूद हैं या नहीं है. Now, let me also show you another slide of a patient of hypospermatogenesis. So, just see over here. You can see this dilated tubule. आप देख रहे हैं बाकी सब पटके हुए से लग रहे हैं. This appears to be kind of opaque, slightly yellow, dilated, which is going to have a dilated seminiferous tubule, which we are going to take out over here. You can see over here, none of these except for this area would have a tubule, which we again taking out to be tested. Now the trick is to be able to identify them, which can only come with practice. And the fact that you continuously need to be in touch with your embryologist, who needs to keep on telling you where they have found sperms, because then your mind knows this is an area which I need to see. Just see over here. So this was hypospermatogenesis. The earlier was a late maturation arrest. Now let me go on to show you how much the advantage is there. So if you see the first, it's a micro-TESE specimen. It's a TESE specimen. You can see the amount of tissue which is taken out. Now what we do with this tissue of a TESE tissue is normally we would slice it, cut it, which will normally done with two needles, so as to open and chop open, chop open every piece like this. Just pulverize it. And you can see very clearly in a TSA sample, we are pulverizing it to make it like this when we are going to take it under a microscope. So when we take this under a microscope, this is how it appears to be. And when we see this under a microscope, we're going to find sperms in this. Now let me show you a micro-TSE sample. So this is a sample which we have. We are cutting and mincing this sample. We chopping it off slowly, doing it to a level that we have very, 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 very small areas. Now this is what we're going to pulverize, chop off, so that these may open up and sperms may come out. And these are the sperms. This is how it looks. Now this is what we are going to take to the microscope. And under a microscope, we're going to observe. And this is when we are going to find sperms in this and use those sperms. Now comes a TSE sample. TSE sample I showed you, micro-TSE sample was a very little bit of tissue. Now I'll show you what we do with a micro-TSE sample. I shown you a TSE sample earlier. So in a micro-TSE sample, what we need to do is immediate handling. In a TSE sample, we have taken it out and big piece we have sent, we have closed. But over here, we need immediate handling and we need temperature control, which needs to be taken as I had told you. We need a 37-degree Hippies buffered medium with 5% albumin within 5 minutes to avoid cold shock. And we do mechanical mincing under a stereozoom microscope using very fine needles until no intact tubule is present. And we express all this fluid into a 10 microliter droplet and scan for 30 minutes at 200 to 400x. Now, let me show how we do it in our lab. So what we do over here is, you can see over here, we have taken this specimen and it's a very different specimen from a TSA sample. So what we do over here, we just cut all that specimen with a needle so as to take out whatever is there inside it, literally pulverize it. And after we have done that, we would take out, and this is another thing which we normally do with the syringe end, so that we could squeeze out every sperm which may be present in this particular tissue. Once this is done, then we are clear we need to take it into a microscope, under a microscope. So now what happens is you've seen under a microscope, you have not found. What is the next step which you could do? So in the next step, what you could do is you could centrifuge the residue. And after centrifuging the residue, you could give it enzymatic treatment. So what we normally do is we give them collagenase 4 treatment, and we prepare this 1000 international units and with DNase 25 microliter per ml. And this we do in Hippies medium and gently agitate for 30 to 60 minutes. Then we dilute, centrifuge, and see again and re examine. And believe me, we get a lot of sperms in those specimens in which we have not got with mechanical mincing. So there is a lot of work which goes into it, not only in the surgeon's hand, but also the embryologist's hand. तो आप ये समझिए, there is a testis which has focal spermatogenesis कहीं कहीं हो रही है. आपने पूरी टेस्टिस खोली, आपने माइक्रोस्कोप के नीचे पूरी टेस्टिस में ढूंढा. If there is a seminiferous tubule which appears to be having sperms, you take out those seminiferous tubules. All these seminiferous tubules are chopped, squeezed. You examine if there is a sperm, pick out the sperm. If it is not there, you do enzymatic digestion, and you then again look for a sperm. And if you find a sperm, then this is where you would go an ICSI. And in this ICSI, there is one thing very clearly: if there is blood contamination, it's fine because that helps us in finding a sperm. I'll show you how for us. I mean, a lot of people use an erythrocyte buffer, but this is what we do. I'll just show you now. See, so what we do over here is, if you can see over here, we're doing an ICSI. We're trying to find a sperm, and the sperm is not found anywhere. Now, soon you will see one sperm, and you can see it against a background of RBCs. The RBCs are all these red blood cells, and you are going to find one sperm, and you slowly will pull that sperm out. Take that sperm in the needle, hold the egg with the other pipette, inject the egg, take a little bit of cytoplasm, and place the sperm back into the cytoplasm. So an ICSI has been done with the sperm of a man. So there is a lot of work which goes into it. This is a lot of work and a dedicated work around the table of an andrologist, of an embryologist, of an endocrinologist, of the reproductive endocrinologist. But you know, it doesn't end over here. This is what I'm trying to tell you. Now, in case you get sperms which are less, cryopreservation of these special sperms is important. So you could do it normal cryopreservation, or you could do a vitrification. And in vitrification, in these samples, you can get up to 60% post-thaw motility. So therefore, you can vitrify them in small aliquots. And this is something which has been very helpful to us, vitrification. Now, predictors and decision support. Now, this is most important. Every doctor who's listening to me now has to take a slide of this, a picture of this, which they can use. I do all this because I really want you to understand that helping our own patients is most important. So, just understand, in case there is a histology of late maturation arrest of spermatogenesis, the chances are that you may get up to, in hypospermatogenesis, up to 70%, 80%, in maturation about 40%, and Sertoli only 20%. The testicular volume, if it is more than 8 ml, it is significant of getting a more sperm retrieval rate. FSH isolated will not happen. You have to combine it with everything. But in case the FSH is high, there is a chance of derm cell dysplasia. and sperm retrieval rate goes down. The maximum which I have till date been able to get sperms in, it was 115 FSH. I got sperms in this patient. Now, a positive FNA mapping helps you in getting sperms, and the surgeon and center volume. See, this is um, it's the man behind the machine over here. So the learning curve is high, at least 50 cases, and any high volumes center should have a sperm retrieval rate of about 50%. So any complex case you have needs to be ideally referred if they want to have their own baby. Now, post-operative management is 24 hours. You have to give scrotal support. Few people give ice packs, I don't. After 7 days, you still continue the scrotal support. It normally heals well. 3 months, measure testosterone if you need to. Give HCG if the patient wants. 9 to 12 months, normally the patient has recovered completely. And if a re-micro-TESE needs to be done, then an FNA needs to be done before entry. So if I put it all together, till 3 months, hormonal optimization, day zero, microsurgical extraction, 0 to 30 minutes, one size, and after it has come out, 0 to 30 minutes, mechanical mincing, 30 to 90 minutes, collagenase digestion, same day, vitrify surplus. After 1 week, review wound, can go back to work. After 3 months, if you need, test testosterone, and this person, if there is low, may be treated, but normally in micro-TC, the testosterone does not go down. Now, future refinement under studies which are there in the field of micro-TC, in the future, a lot of cutting edge technologies are going to come, have come. One is a multi-photon microscopy. So you integrate a operating microscope with real-time tissue analysis. It differentiates the spermatogenic from Sertoli cells only, and it does it because of its intrinsic autofluorescence. So precision would be there, and it will raise the sperm retrieval rate without extra tissue removal. So this is the first thing which is going to come in the world, or it is being used, and it's in experimental stages. This is something beautiful which will come out. Intraoperative analysis could be done by AI imaging, which will be better, I mean, faster. Laboratory enhancement can be done by automated analysis of the specimen, and detection accuracy may increase. Now, see, one thing is very simple, that you could get a pregnancy from 25 to 45% in them. You could get 20 to 35% live birth rate. Cumulative success rate after 3 cycles in patients like this could be 50 to 70%. No significant birth rate increase if it is present, it is because of the innate genetic problem which the man has. Genetic abnormality inheritance risk is based on the parental factor, and normal childhood has been seen, and long term development risks are not of major significance. In the conclusion, there is a 1.5 times improvement, 60 to 70% complication reduction, and 50 to 70% cumulative birth rate. One thing needs to be done: diagnostic protocols used to be used, treatment and algorithms need to be used, outcome monitoring has been, and quality standards. What is the verdict? The verdict is very simple. It is just excellence for the patient, and rigorous training can be done for this. If you can have 70% retrieval rate, live birth rate, and very little complications, it is great. Why? Do you know why I say this? I say this because man is very sensitive. Man doesn't want his testes to be operated. And if it is operated, you need to be very sensitive to his sensitivity. And it has to be gently. One. Number two, we ultimately are in the larger picture of work which is trying to relieve the pain which people have. The biggest blessing which all of us could have on earth is trying to relieve our fellow human beings, and we are blessed as doctors, as gynecologists, IVF specialists, to relieve that pain and stand with them when they are most vulnerable. Asuspermia is something which is very painful to a man, psychologically, emotionally, physically, and even in a relationship. For him to have his own child is priceless. And I'm sure, I'm sure, after seeing this, you would realize that 70% of azoospermic men can have their own babies. At this ISAR meeting where I'm addressing, first of all, let me be very, very thankful to all the office bearers, all the doctors who've invited me, the president, vice president, the organizers over here, who are brilliant, who speak to me so sweetly and have invited me here. But most importantly, जो जज्बा आप में है कुछ वाकई में करने का हर डॉक्टर के लिए कि वो सीखे, अपने एरिया में करे और इस पेन पॉइंट को हर इंसान का कम हो। कहानी अपनी नहीं है, कहानी उन पेशेंट्स की है जिनको इसकी ज़रूरत है, इज़ ब्रिलियंट। Thank you very much once again, everybody at ISAR, everybody who's joined here. I'm extremely thankful to you because your giving me this time gives me an opportunity to tell you where the world is going. Thank you very much. God bless you all. Micro-TESE is more than a technique, it's a testimony of hope. Every retrieved sperm is a possibility. Every trained doctor multiplies it into miracles. I'm sure you have liked this particular training program. Uh, that's what it's meant to be, to help people who don't have children. Love to make it for you, and I will keep on coming on with new videos, new training programs, and things which will help our patients and bring us to an area we're able to do better things for people in our society. And this is something which I would like to take you into, stories from the frontier of reproductive medicine. I am Dr. Sunil Jindal. Thank you for being here on this beautiful journey with us.